And unfortunately, no matter how many Daily Mail articles there are saying there's one stretch that can instantly cure your low back pain, we know that that's not true. And unfortunately, the same's for tape as well. So I started to have a little look at the research. This is the Lancet guidelines from 2016. If you haven't looked at those, thoroughly recommend them. They are a deep, deep, deep dive into low back pain and its management. So I thought that's a pretty blooming good place to start for tape research. And they essentially form these tables around what's recommended and what isn't recommended. And there's no mention of tape in there whatsoever. So that was a bit of a kind of bit where I realised I probably needed to look a bit differently. So there's varying evidence for everything we do, as we've already heard, but tape doesn't come into those guidelines at all. So then I thought, well, I'll look at the NICE guidelines as well. And then looked at their excluded interventions list, and you notice kinesio taping and various taping on there just doesn't come out either. So taping as a general, you're not going to find it on many guidelines. So therefore, I've got to zoom in and do the hard work for us. So the two different types of tape, kinesio tape is this brightly coloured, stretchy stuff that originated from Japan in 1970. Colourful and stretchy, it goes to about 120 to 140% of its original length. And it got everybody really excited. During the 2012 games, you'll have seen loads and loads of people mummified in this stuff. And the reason for that was essentially it seemed to excite or depress muscle activity, depending on whether you put it from origin to insertion or insertion to origin. Now, most of the research has come back on that and gone, that doesn't happen. It doesn't excite muscle tissue in that way. The direction of travel doesn't really make too much of a difference. The other type of tape is zinc oxide or Luca tape, so a lot stiffer, generally used when you want to make something a bit more rigid. It gets its name from the zinc oxide-based adhesive on the back of it, and it's much more of an immobilization tool. It needs a base layer to reduce chafing or an allergic reaction underneath. And so therefore I decided to look at which one. And essentially there's no evidence behind one or the other. The most recent research tends to look at kinesio tape just because London 2012 really put it on the map. So therefore, when you're looking at whether to consider this as a treatment option for your patients, you can safely say, pick the one that A, you're the most comfortable with, and B, the patient is the most comfortable with, because there's no evidence when you're trying to choose between the two of them. In my experience, KT is a bit more friendly. Probably don't need as much tape as she's got on, but it does a pretty good job. So the evidence in favour, there is evidence that sticking something on the skin seems to make a difference. But there's very, very little difference between whether that's KT or whether it's just me-pour masking tape, something similar. So sticking something on the skin seems to work. As we've discussed earlier, the pain gate theory, rubbing something better, does help. So therefore, sticking tape on it does seem to have an effect. And that works at baseline, works at 48 hours, and it works at 7 days. And they looked at it in an emergency department and an emergency department setting as well, where they looked at people who'd had traumatic shoulder injuries, and they found that sticking some tape around there actually helped reduce pain outcomes following treatment as well. So it's there. Like, it's a good treatment, it's a good pain reliever. It's safe, it's non-invasive, it's nice. But almost all studies looked at chronic pain apart from that ER study, and there's very, very little research on acute pain management in low back pain for kinesio tape. The effects seem to be short-term. As I said, they seem to show some effect at 7 days, but nothing beyond that. Some studies have shown that they reduce pain and disability, but it's too small to be clinically worthwhile. So essentially, when you look at tape, it's pretty good, but it's not that good. That's the takeaway from this really. So I looked instead at how I tend to manage people in the clinic. This is the one I tend to use for low back pain. It's pretty simple. So 2 stripes going vertically just around the paraspinals, and then the horizontal strip just around. You just ask the patient, where's the pain, with the most, point with one finger, stick some tape horizontally across it. The other one that I do is just for postural awareness, so just to allow people just to be a little bit more shoulders back. But we haven't discussed this at all, but essentially I apply the context as well as the tape to just go, There is no evidence that shows that posture relates to low back pain or vice versa. So therefore, I really apply that context as well as going, I'm not trying to stick you in this posture because that's going to make you better. It's just essentially just encouraging people to move and encouraging people not to slump for longer than they need to. So conclusions, is there a place for tape? Yeah, it's good, but it's not that good. And that's the real kind of takeaway from this. I think it has a really good effect on acute pain. And essentially, if you have somebody coming into the clinic who is really, really in lots and lots of pain, it's something you can throw at them during a very, very painful episode, and it can therefore be useful. But sticking something on the skin does some good, does the pain gate theory, but as we've already discussed lots and lots of times, it must be a portfolio of treatment anyway. If you are purely treating people by just sticking something on the skin, you're missing quite a lot, but it is useful in those very, very early stages and just to encourage people to move a bit more.
Amazing, thank you, Ben. Thank you.